Assalamualaikum and good day everyone. Welcome back to last lecture for PHC 634 Pharmacology of Anti-Effective Agent. So for this week, we are going to discuss on the clinical overview of antimicrobial agents. As usual, here is the learning objective for this week lecture. So at the end of this week lecture, you should be able to understand the general algorithm for the treatment of bacterial infections. Aside from that, you should be able to understand the underlying reasons of drug choice based on the pharmacological consideration of drugs as well as the patient's conditions, and you need to be able to discuss the factors that cause antimicrobial failure. Here is the general algorithm for the treatment of bacterial infections that we are going to discuss one by one. At first step, the doctor should be able to diagnose any bacterial infection based on the clinical symptoms or clinical signs. If there is confirmed positive of bacterial infections and the sensitivity profile of these respective bacterial infections are available during that point of time, so the doctor might want to treat the bacterial infections with the appropriate antibiotics. If there is no culture and sensitivity report that available during that point of time and the bacterial infections is likely to occur, the doctor might want to give the empiric therapy before the pathogen responsible for a particular illness can be detected. As mentioned in Mr. Harris' lecture, this empiric therapy is so much important due to early intervention will improve the clinical outcome. At the time that the pathogenic organism responsible for that particular illness can be identified, so this empiric therapy is optimally modified to definitive therapy, which means that we narrow the coverage of the bacterial infections and given for an appropriate duration based on the clinical practice guideline. So in Malaysia, we're using this National Antimicrobial Guideline 2019 that you can download it in the website of Ministry of Health. So during the treatment regime, we need to measure all the signs and symptoms as well as the clinical data to show any improvement of the antibiotic therapy. So if the patient shows remarkable improvement, then they need to complete the course of treatment. If there is no significant improvement within these 3 days, alternative or additional diagnosis should be made and the patient requires changes their antibiotic therapy. Okay, so let's discuss one by one, starting to formulate a clinical diagnosis of microbial infections by using all available data and symptoms during the first time of view. So the patient must having fever, which is the temperature more than 38 degrees Celsius. Aside from the white blood cell count must more than 10,000 millimeter per millimeter per cubic, and shows any local signs such as inflammations or hypoxemia or any greenish in the sputum or smell disturbance. So at the same time, the clinician should determine whether there is any clinical syndrome that compatible with infections such as pneumonia, cellulitis, and sinusitis. Bear in mind that do not start the antibiotic when patient having only having cough or cold or any virus sore throat or uncomplicated cystitis. As mentioned earlier, infected body materials must be sampled before institutions of any antimicrobial therapy. This is important. By doing this gram-stain positive or gram-stain tested, as you can see in this graph, it can reveal type of bacteria, and using the acid-fast stain is able to detect any mycobacterium or actinomycetes. Please bear in mind that do not delay in obtaining infected fluid or tissues until after the empirical therapy is started, because of it might result in false negative culture result or any changes or alteration in the cellular and chemical composition of the infected fluids. So the culture and sensitivity samples can be blood, bone marrow aspirate as shown in this picture, cerebrospinal fluid, stool, pus, urine, sputum, or sterile swab of eye, ear, nose, throat, depending on what type of illnesses that patient experience. So during this sampling is the most crucial point, and is usually problematic with cultures that obtain from the skin, oropharynx, nose, ears, eyes, because of this surface are heavily colonized with a wide variety of bacteria, with some of which can be pathogenic in certain settings. So these steps are crucial, and clinicians must be cautious in determining whether the organism that recovered is a true pathogen or whether it's a contaminant, or part of the normally expected flora. So the MIC, or minimum inhibitory concentrations, provide useful information for comparing the susceptibility of organism to the antibacterial drugs that will be discussed more deeper after this. And at the same time, this MIC also able to identify any drug resistant towards specific microorganism. So as you can see in this diagram, it shows that the clear tube is at 3 microgram per mil and 4 microgram per mil, and we can say that the minimum inhibitory concentration of this bacteria is 3 microgram per mil, which is the lowest concentration that can inhibit the growth of the bacteria. Here is the summarize of all antibiotic agents that you have learned in previous week by Dr. Ling Xiaomeng as well as Dr. Safarina. So generally, antibacterial drugs can be further classified into 5 main groups according to their mechanism of action, which are antibiotics that inhibit the cell wall synthesis, including the beta-lactams such as penicillin, cephalosporin, carbapenem, and monobactams, as well as the vancomycin and bacitracins. There are also some antibiotics able to inhibit the nucleic acid synthesis by acting on DNA gyres such as quinolones, DNA elongation such as actinomycin, and RNA polymerase. Some antibiotics able to inhibit the protein synthesis by binding at the 30S subunits such as tetracycline, aminoglycoside, as well as nitrofurantoins, and 50S subunits such as macrolides, clindamycins, chloramphenicol, and linezolids. Polymycin and daptomycins able to disrupt the cell membrane integrity, and the cotrimazole and other sulfonamides able to block the pathway and inhibit the metabolism by disrupting the folic acid synthesis. This antibiotic can be further classified as bactericidal as well as bacteriostatic. So bactericidal drugs, which the drugs that kill bacteria, and bacteriostatic drugs that prevent their reproductions. But please do not confuse. These differences is relative only. Most of the bacteriostatic drugs often shows bactericidal at high concentration as well as in the presence of host or infected patient defense mechanism. If the local or systemic host defense being impaired, then bactericidal agent should be selected over bacteriostatic. And not only that, bactericidal agent also should be preferred, especially for the treatment of endocarditis and any other endovascular infections such as meningitis and infections in neutropenic cancer patients. So these bactericidal drugs can be further divided into 2 subgroup agents, which is the one that exhibit time-dependent killing, such as beta-lactam and vancomycin, and agents that exhibit the concentration-dependent killing, such as aminoglycoside and quinolones. As you can see in this diagram, bactericidal activity must be continuous as long as the plasma concentrations is greater the minimum inhibitory concentrations. So this is the time dependent killing of the bactericidal agents such as beta-lactam and vancomycin. In contrast, for the concentration-dependent killing, such as aminoglycoside and quinolones, the rate and extent of killing increase as the peak of drug concentration being increased. Not only that, it also exerts post-antibiotic effect. So what's the meaning of post-antibiotic effects? So this post-antibiotic effect, it shows that the bactericidal activity can occur even though the plasma drug concentrations below its MIC value. So that is why aminoglycosides such as gentamicin can be used as once daily dosing. It is due to the persistence of aminoglycoside binding to the targeted site of action, as well as the remaining bacteria are unable to grow or unable to reproduce due to their requirement to synthesize new protein for growth. You might want to consider another factor such as pharmacokinetic considerations before prior initiating any antimicrobial regime. So the one of it is through the route of administrations, because most of the antimicrobial agents have similar pharmacokinetic properties when given orally and or when given intravenously. So the drugs such as tetracycline, cotrimoxazole, quinolone, clindamycin, rifampin, as well as linezolid shows equally effective when given orally or given intravenously. So the advantage when given orally is less costly and result in fewer complications compared to given intravenously. However, intravenous route is preferred, especially for critically ill patients who with bacterial meningitis and endocarditis that require substantive treatment, as well as the patient with nausea, vomiting, gastroctomy, or any gastrointestinal disease that can impair the oral absorptions. Another factor that you might want to consider is the condition that can alter the antimicrobial properties, especially when the patient having renal or hepatic impairment, which will reduce the elimination of the antimicrobial drugs. So the failure to reduce the drug dosage may cause the toxic effect. So here are the list of drugs or antimicrobial agents that require dosage adjustment, especially in renal impairment patients. Meanwhile, this is the list of the drugs that require dosage adjustment, especially in hepatic impairment. Citofovir, methenamine, nalidixic acid, nitrofurantoin, as well as long-acting sulfonamides cannot be used in renal impairment patients. So please bear in mind, if not, it will harm to the patient, which cause the toxic effects. Conversely, patients with burns, cystic fibrosis, as well as trauma require increased dosage requirement for selected agents. Another factor that you might want to consider is the drug concentration in body fluids. So it's easily, most antimicrobial agents are well distributed to the most of the body tissues, but not all are able to penetrate the blood-brain barrier to achieve the cerebrospinal fluid concentrations. So, however, uh, in the meningitis incidents, the cerebrospinal fluid concentration of many antimicrobial agents has been increased during these incidents. So in clinical practice, another thing that you might want to consider the serum concentration monitoring, which is routinely performed on patients that receiving aminoglycosides such as gentamicin, kanamycin, as well as the vancomycin and flucytosine. So the flucytosine serum concentration has been shown to reduce the toxicity when the doses are adjusted to maintain the peak concentration below than 100 microgram per ml. Patients must be monitored carefully for a therapeutic response after instituting the antimicrobial therapy. Culture and sensitivity report from specimens that sent to microbiology laboratory must be reviewed, and the therapy must be changed accordingly based on the susceptibility and resistance result as shown in this antibiogram. So patient monitoring should include many of the same parameters that used during the diagnostic infections, which including the white blood cell count must less than 10,000 millimeter cubic, and the temperature must be less to 38 degrees Celsius, which is must start to normalize, as well as the physical complaint from the patient also should be diminished, such as decrease the pain, decrease the shortness of breath incident, or any cough or sputum productions, as well as the appetite of the patient should be improved, and the radiology improvement can lag behind the clinical improvement. Another thing that you might want to consider, as I mentioned earlier, determination of the serum or fluid level of antimicrobial can be useful in assuring their outcome or preventing any toxicity. So not much antimicrobial that requires serum concentration monitoring. So these include the aminoglycoside, flucytosine, as well as the vancomycin. So achievement of the adequate aminoglycoside concentration within the first few days of therapy of gram-negative infection have been correlated with better therapeutic outcome. So use of the agent with the narrow spectrum of activity against identified pathogens are recommended. If anaerobe are suspected, even if they are not been identified, so anaerobic therapy should be continued. Patients who are failed to respond over 2 to 3 days require a thorough re-evaluation. So a variety of factors may be responsible for this lack of response to the therapy. One of it is the malabsorption. Malabsorption can occur of a drug product because of the gastrointestinal disease such as short bowel syndrome, or a drug interaction such as complication of fluoroquinolone with multivalent cations, resulting in reduced absorption, which lead to potentially subtherapeutic serum concentrations. The common cause of failure of therapy also is due to the poor penetration into the site of infections. This is especially true for sites such as the central nervous system, eye, and as well as the prostate gland. Drug failure also can result from the drugs that are highly protein bound or that are chemically inactivated at the site of the infections. Accelerated drug elimination also possible cause of the failure of antimicrobial therapy. This can occur in patients with cystic fibrosis or during pregnancy, when there is more rapid clearance or larger volume of distribution can result in low serum concentration, particularly for aminoglycosides. Another factor that you might want to consider, especially to those patients who are failed to the current antimicrobial therapy, is the host factor itself. So you need to evaluate the patient itself when the patient is not responding well to the antimicrobial therapy, especially to the patients who are immunosuppressed patients such as granulocytopenia from the chemotherapy or AIDS. So these two types of patients respond poorly to the therapy because their defense mechanism itself inadequate to eradicate the infections despite adequate drug regimens. A good example is the poor response of infection in granulocytopenic patients when their white blood cell count remain low during the therapy. In contrast, when the granulocyte count increase during the therapy, they shows way much better response to the antimicrobial regime. Another factor that you might want to consider is the other host factors that related to the need for surgical drainage of these abscesses or removal of any foreign bodies or any necrotic tissues. If these situations are not corrected, it might result in persistent infections and may cause bacteremia incidents. And the most common reason of failure of antimicrobial therapy is due to drug resistance. So the mechanism of drug resistance can be broadly divided into three groups. The first one is inactivation of the antimicrobial agents. The second one, restriction of entry of the drug into the bacterium by alter the permeability or efflux pump such as sulfonamides and tetracycline. And another one is the modification of the bacterial target by changing the modification of enzyme, which will reduce the affinity for an inhibitor, or alter the organelle itself, which will cause reduce the drug binding properties such as erythromycin and the bacterial ribosomes. So the increase in resistance among these organisms is believed to be a result of continued overuse of antimicrobial in the community as well as in the hospital, and increasing prevalence of immunosuppressed patients that receiving long-term suppressive antimicrobial agent for the prevention of any infections. So this overuse of antibiotics, especially in the agro culture setting, will cause bacterial resistance, which it can become a serious clinical problem that rendering previously useful drugs to inactive drugs. That's all for this week lecture and the end of this course lecture. So not only that, this will be my last lecture for all of you. I want to sincerely apologize because I am not a good lecturer and I am not good at delivering the knowledge to all of you. I hope that all of my lecture is giving you some benefits, especially preparing you guys for your clinical year. I wish you all the best for your clinical year and your future endeavor, and I would like to express my gratitude for being patient with me. Thank you everyone. Bye.